Today's topic is iron deficiency anemia. Iron deficiency anemia is a condition in which the total body iron content is decreased below a normal level and iron stores are depleted. It is the most common type of anemia in the world. It typically results when the intake of dietary iron is inadequate to maintain the level necessary for hemoglobin synthesis. For most adults, blood loss is the cause of this anemia. Risk factors include a history of ulcers, gastritis, intestinal hookworm, gastrointestinal tumors, malabsorption, or diet very high in fiber. Prevents iron absorption. A very high diet in fiber prevents iron absorption. The most frequent cause in premenopausal women is menorrhagia. Chronic alcoholism often causes inadequate iron intake and loss of iron through blood from the gastrointestinal tract. Clinical manifestations of iron deficiency anemia are symptoms of anemia, fatigue, irritability, numbness, and tingling of extremities. Symptoms in more severe cases: smooth, sore tongue, brittle and ridged nails, and angular cheilosis means mouth ulceration. Pica is unusual craving for clay, ice, or starch, a history of multiple pregnancy or gastrointestinal bleeding. Hemoglobin proportionately lower than hematocrit and red blood cell count. Serum iron concentration low. Total iron binding capacity is high. Serum ferritin is low. Diagnostic evaluation are bone marrow aspiration, laboratory values including serum ferritin levels. These indicate iron stores, blood count, hemoglobin, hematocrit, red blood cell count, mean corpuscular volume, serum iron level, and total iron binding capacity. Medical management: search for the cause, which may be a curable gastrointestinal cancer or uterine fibroids. Test stool specimens for occult blood. Administer prescribed iron preparations, oral, intramuscular, or intravenously. Avoid tablets with enteric coating, may be poorly absorbed. Continue iron for a year after bleeding has been controlled. Nursing management: administer intramuscular or intravenous iron in some cases when oral iron is not absorbed, it is poorly tolerated, or is needed in large amounts. Administer a small test dose before intramuscular injection to avoid risk of anaphylaxis. It is greater with intramuscular than intravenous injections. Also, you can see nursing management under anemia for additional information. Providing home and community-based care. Teaching patients self-care. Advise patient to take iron supplements an hour before meals. I will repeat, advise patient to take iron supplements an hour before meals. If gastric distress occurs, suggest taking the supplement with meals and after symptoms subside, resuming between meal schedule for maximum absorption. Inform the patient that iron salts change stool to dark green or black color. Advise the patient to brush and floss teeth frequently because ferrous sulfate is likely to be deposited on the teeth and gums. Take liquid iron through a straw and rinse mouth with water. Teach preventive education because iron deficiency anemia is common in menstruating and pregnant women. Educate patients regarding food sources high in iron, example organ and other meats, beans, leafy green vegetables, raisins, and molasses. Advise the patient to take iron-rich foods with vitamin C to enhance absorption. Inform the patient to avoid taking antacids or dairy products with iron. Provide nutritional counseling for those whose normal diet is inadequate. Encourage patient to continue iron therapy for total therapy time, that is 6 to 12